Very good evening. I'm Dr. Anupama Pujarke, Professor of Surgery in Saptagiri Institute of Medical Sciences. And at the outset, I thank Dr. Harish and also International Society of Coloproctology for giving me this opportunity to talk on a most important topic which we come across in our day-to-day surgical practice. My topic is etiopathogenesis and clinical presentation. I think all of you are practicing surgeons and I think you all are aware of it. As a part of completion of this course, let me tell few words and finish it fast. Thank you. So all of you know the word is derived from the Latin word. Pilus means hair, nidus means nest, so it's a nest of hairs. And it was noted most of the cases were reported in World War II, where almost around 80,000 soldiers were affected. Most of them were jeep drivers, and that's why the term came as jeep disease. It's a condition found in natal cleft overlying the coccyx and consisting of one or more midline openings that communicate with a fibrous tract. However, it can occur other regions also, like interdigital areas in hairdressers, umbilicus, axilla, and many other regions, and there are many case reports have also been reported in a very not a common areas. History: in 1833, Herbert Mayo first described the pilonidal sinus as a blind-ending sinus containing hair in the sacrococcygeal region, and Hodges coined the term pilonidal in 1880. And Buey noted the prevalence of this in male and military recruits who drove jeeps, and it's characterized as a jeep disease. It was also mentioned in Sushruta Samhita, and Sushruta also described about the sinus with the hair in it, and also he described about the management, which includes, I think the Ayurvedic people will understand, the Agni Karma and the Kshara Sutra. The incidence of disease, mainly the Western incidence are there, 26 per 1 lakh people. It occurs more common in men than women, typically seen in late teens and early 20s, with a mean age is around 21 years in the men and 19 years in the women. And this is the sacrococcygeal area where it is commonly located and which is of interest of today's management topics. So etiology, till today it is again a controversial. There is lots of proponent which used to happen for the congenital and acquired. Previously it was thought mainly around 1878 when Professor Fear and till 1951 Professor Stone, lots of theories have been established thinking that it's a congenital origin. They thought that pilonidal sinus disease occurs because of residual epithelium in the spinal canal and skin, or when the hair follicles enter to interspace formed by incomplete fusion occurring as a result of defective embryonic development. They proposed many theories, medullary canal theory, many theories, but these theories were not proven and failed to explain many factors, such as the pilonidal sinus occurring in other areas than the sacrococcygeal region. And they found that this disease occurs much in an older age group than the common congenital disorders are noted. And the recurrence of this even after a radical excision was not explained in this congenital disease. And the blind end, the tip of the hair was found towards the blind end of the sinus rather than in the wall. So there are lots of questions were there in the congenital theory. Later, again, it was also proponents of acquired theory. Mainly we have Bascom, who thought hair follicles become infected under the effect of gonadocorticoids, and when they are filled with keratin during the puberty, and this gets infected and forms an abscess tract, and hairs in this tract pierce the skin while they are still attached to it and pulled into the deeper region due to vacuuming effect of the gluteal muscles to form a sinus. And this vacuuming effect was seen mostly when there is a prolonged sitting. That's why it is seen most of the people who have occupation where there is prolonged sitting. Okay, and it was rarely seen in people who are bedridden or the people who are elderly, even though they are sitting for a prolonged period. Caridakis came with hairs move towards the follicle and enter like a drill, and that forms a very weak part of the skin through which the other hairs will enter. And this theory was kind of validated by, it also explains why the pilonidal sinus occurs in other areas other than sacrococcygeal region also. Kyriakis also proposed the factors that promote the pilonidal sinus. He took the hair factors and the force with which it enters and the vulnerability of the skin. He gave it like hair factors are the what kind of hair, straight hairs or coarse hair, scaliness, and also the F factors like depth of the cleft and the narrowness of the cleft and the friction between the sides of the cleft. And vulnerability depending upon the softness of the skin, maceration, erosions, wounds, like that. So he came up and he formed a formula actually to see the risk in the developing pilonidal sinus. So altogether, it is a combination of buttock friction and the shearing forces in that area which allows hair to shed and break, and they collect in the gluteal cleft to drill through the midline skin or infection of the hair follicles that allows hair to enter the skin by suction created by the movement of the buttocks, and this creates a subcutaneous chronically infected midline tract, and this is a primary tract through which there are many secondary tracts which will arise from this and open into the skin as a discharging sinuses. So the primary tract usually lined by the squamous epithelium and where the hairs are freely located. Secondary tracts are the one where it is lined by granulation tissue and there are a lot of hair follicles, leukocytes and hemosiderin containing macrophages are formed. So who will develop the pilonidal sinus? There are lots of risk factors have been explained. There are many, few I'll name it as positive family history of the disease. There have been seen reports where there are siblings getting affected and the hair texture which runs in the family also is becoming a risk factor. Elevated, that is obese patients, poor hygiene, hirsutism, deep natal cleft anatomy and occupation which needed prolonged sitting and excessive sweating. There are lots of case reports which are proving and disproving these risk factors. Let's not go into this detail. Clinical features, they may be totally asymptomatic form. Almost around 11% of people may present just a pits which do not cause any symptoms. And acute abscess form where there is a swelling and all the abscess features with erythema, redness and constitutional symptoms. Around 50% which is there in the literature which I found. Chronic disease form is seen when this abscess bursts out and tract remains and it forms a chronically discharging sinuses, and when it repeatedly occurs, it can present as a chronic complex pilonidal sinus. On examination, there are lots of classifications are available in pilonidal sinus. So one is popular is Tezzel's classification, where there is type 1 is presence of asymptomatic pit, type 2 is acute pilonidal abscess, type 3 is pits restricted in the navicular area, type 4 is extensive sinus disease with sinus opening outside the navicular area, and type 5 recurrent pilonidal sinus disease after surgical treatment. There are many other classifications also available, let's not go into the detail. So how do you investigate? Actually, pilonidal sinus is a clinical disease. Diagnosis is based on our history and the clinical examination. So whom do we investigate? When you are uncertain about the diagnosis or if you are expecting a complex pilonidal sinus and when the tract goes more caudally. Usually the pilonidal sinus tract usually goes toward 90% it goes towards cephaloid region. So because it shows along the growth of the hair follicle. Very rarely it goes caudally towards the anal region. But however, there are case reports which also has told endoanal pilonidal sinuses also. So when you have a diagnostic dilemma or any uncertainty, then ultrasound can be done. Here there is an ultrasound which shows hypoechoic, the tract pilonidal sinus, and in that you can see the hyperechoic lines which shows the hair in it. And when you do Doppler, there is a hyperemia around the tract which shows the inflammation. MRI is again, it is 86% sensitivity and 100% specificity in pilonidal sinus which shows the tracts, collection and the extent of the disease. So here is one with a T2 weighted images of the sagittal section showing a tract extending as a tubular tract. This is axial section, the tract extending and there is a skin opening in it. So however, these investigations are reserved. So summary, pilonidal sinus disease is a complex condition arising from the combination of risk factors. There are many theories proposed, however, exact etiology is still controversial. Diagnosis is based on the clinical features, imaging reserved in case uncertainty or complex pilonidal sinus. These are my references. Thank you.
Thank you, ma'am. I request Dr. Harish sir to present the memento to Dr. Anupama Pujar, ma'am.
By the time I asked Dr. Srekar Pai for his talk, Limburg flap.